Hello, everyone. This is chapter 6. These are the anti-inflammatory drugs that start on page 83 in our textbook. All right. Now, when we talk about inflammation, we know it occurs when something bad is happening in the body, and the body starts to try to reverse it. So that's what inflammation is. Our immune system, it will start taking over, and then it will try to start reverse it and try to make everything okay. It tries to heal the body. Anything that ends in itis, this means inflammation of something. So, example, if you have bronchitis, that means inflammation of the bronchi. If you have dermatitis, that's inflammation of the skin, and so on and so on. So anything that ends in itis, you know there's some type of inflammation going on. When inflammation happens, you may see an increase in your white blood cells. And we know a normal white blood cell count is 5 to 10,000. Bad thing is that the inflammatory response sometimes can cause tissue damage if the response is really, really big, and that's what we do not want to happen. So this is when we use an anti-inflammatory drug. That's when it comes in play, when we have that a lot of inflammatory response happening and that tissue damage that we want to stop. So we use those anti-inflammatories. What anti-inflammatories will do is they will actually decrease or it will prevent the inflammatory response. And this can help with pain, and this will help prevent that tissue damage. And that is very important. We want to try to prevent and save our tissues as much as possible. We use anti-inflammatory drugs to treat acute problems like asthma and allergic reactions, chronic problems such as autoimmune diseases where the body starts to attack itself and normal cells and tissues, and that would be like rheumatoid arthritis, MS, psoriasis, lupus, etc. We use anti-inflammatory drugs to get the disease under control, and then it will help decrease that tissue damage from occurring, so people can have normal movement and all. We use anti-inflammatory drugs to get the disease under control. Like I said, we also use anti-inflammatory drugs for organ transplant patients because it will suppress the body's inflammatory response so it doesn't attack the donated organ. Anytime you have an organ transplant, the body considers it as being foreign, and these people have to take these anti-inflammatory, anti-rejection medications to prevent rejection for the rest of their lives. So they have to be on these medications. We can find them. They are prescribed. We can find them over the counter. Usually if we find something over the counter, it's always going to be lower doses. We know that. Okay, so there's 5 categories of anti-inflammatory drugs that we're going to talk about. The first one is very important, corticosteroids. Second one, people take daily, NSAIDs, which non-steroidal anti-inflammatory drugs. Then we have our antihistamines, our leukotriene inhibitors, and then of course our DMARDs, or disease-modifying anti-rheumatic drugs. So the first thing, like I said, we're going to talk about, of course, is our corticosteroids. Now, corticosteroids, and read up on the anti-inflammatory process, read up about the adrenal glands and things like that, because that's going to help you try to understand the anti-inflammatory process. So with corticosteroids, it is close to the cortisol that is produced by the adrenal glands. And you can see the adrenal glands on page 89. It's above the kidneys. I always call it the Donald Trump hair of the kidneys. Cortisol is a stress hormone. It is used in our fight or flight response. It decreases inflammation. It suppresses our immune system. It can regulate our blood pressure. It increases our blood glucose level. We use it in digestion. It digests with like the carbohydrates, fats, and proteins. It will help with sleep, also our wake cycle. It will boost our energy in stressful situations. So it's very important that we have it. If we don't have that cortisol, then we would die because it's a part of our life. Used for anti-inflammatory, we also use corticosteroids for anti-allergy properties. It will not cure, but it will help with tissue inflammation, and that's why we're going to be taking it to help with the inflammatory process. There are different routes that you can take corticosteroids. They're oral, parenteral, that's either IM or IV. We can inhale them. People who have asthma use inhalers. We can use topical, injected into the joints. We can give it rectal. We can also do eye drops. So there's different ways of corticosteroids, ways of giving it. Now, oral and parenteral forms are prescribed for short periods of time because they may have many side and adverse effects. So they're usually prescribed for a short period of time. They can be ordered longer periods if you can't get the inflammatory under control. So sometimes you are on them for weeks or months. They will cause a decreased production of your white blood cells. And remember, with inflammation, white blood cells attack the cells at the site. Also, it will put the patient at risk for infection. So anytime your white blood cells levels decrease, that puts you at risk for infections. The plan would be to prescribe the lowest dose of corticosteroids to control the inflammation without causing nasty side effects and adverse effects, but having the best outcome. So that is the goal and the plan of corticosteroids. So on page 86 of the book are common corticosteroids that we use. And we use prednisolone is probably the big, dexamethasone, we use a lot of that. For the parenteral forms, hydrocortisone and methylprednisolone, we use a lot of that. And of course, topicals, hydrocortisone, and also the triamcinolone. Those are all used pretty much a lot with corticosteroids. So the goals you can see are they will decrease swelling, decrease redness and pain, but increase the function to the area involved, and that is the biggest thing we want. But they do have side effects, and the side effects are plenty when it comes to corticosteroids, okay? And the side effects, there's many because it affects every cell in the body. Some effects you won't see 5 to 7 days after starting, so you won't see them right away. It sometimes takes 5 to 7 days to start. Some can be months or even longer. On page 87, box 6-1, you can see a picture. I'm trying to find me. Not a picture, but you can see the common side effects of our synthetic corticosteroids, or systemic. Why did I say synthetic? Systemic corticosteroids. Common side effects that we do have could be acne. There is sodium in fluid retention, so people will gain weight. Hypertension, nervousness, insomnia. And they have a lot of emotional changes. They can cry easily and get upset quickly. And this usually starts, that emotional change with corticosteroids will start 1 week after therapy. They maybe start becoming emotional, and that is due to the corticosteroids. With a month of therapy, these drugs can alter your appearance, which is the Cushingoid appearance, and you can, and it will affect a person mentally. And you can see this on page 87 in the pictures. You will get weight gain, fat redistribution. A lot of you'll get the moon face. So people will have a round moon face. They will get actually a little buffalo hump on their back. They're at increased risk for GI bleeds and ulcers. They will easily bruise. They will have decreased muscle mass and strength. Their hair starts to thin on their scalp, but it will increase body and face hair. So it will get thin on top, but I always say thin on top, but it will migrate south. So you'll start getting facial hair. Big time increased risk for infection because we know it decreases the white blood cells and it can cause stretch marks. These side effects will go away after treatment is stopped. Some of them will take some time to go away, but the only thing that will not go away and will be a permanent thing are going to be those stretch marks. Now, adverse effects for our corticosteroids is the biggest thing ever is the adrenal gland suppression, okay? And this happens when you're on for a long period of time, usually more than a week. If you're on corticosteroids for a week, we do not have an issue. You can take it as directed, but after a week, you have to make sure you take that medication on a daily basis and do not stop it without, talking with a physician. But usually more than a week, you'll have that adrenal gland suppression. And this will decrease your immune function because it suppresses the white blood cells. It puts you at risk for infection and also will decrease wound healing. So on page 89, the adrenal gland, like I said, is above the kidney. It produces that cortisol. Corticosteroids mimic the cortisol. So you can only have so much cortisol in the bloodstream. So if you have a decreased amount, it will produce more. The adrenal glands will produce more. If you have an increased amount, it will decrease production. So if levels are very high, the gland will start production, and over time, the gland will start to shrink or atrophy. Okay, so that's why you're taking these steroids on a regular basis. The adrenal gland doesn't have to produce any more cortisol because corticosteroids mimic cortisol, and the body says, oh, I have enough cortisol in my system, I don't have to produce anymore. So that gland will start shrinking. And when it atrophies and shrinks, it will stop producing the cortisol. The only thing is bad is the problem happens if we suddenly stop the steroid. So that's why we have to remember, only if we take it for longer than a week or very high doses, we need to take it on a regular basis. We cannot stop those corticosteroids because the adrenal gland can't start producing cortisol because it has shrunken and it is atrophied. It can take weeks or months for that gland to start producing cortisol. And without cortisol, I already told you, we need it for daily living. We could die without it. So we have to know without cortisol, it can cause a lot of problems. So what we need to do is a person on corticosteroids for long periods of time or high doses have to gradually taper themselves off the medication to get off of it. So the adrenal gland can start reproducing cortisol for the body. So on page 88, box 6.2, there are signs and symptoms of acute adrenal insufficiency. All right, and those are some, let's go to that, page 88. All right, on page 88. And the signs and symptoms of it, we, of course, you can read it. You can have acute confusion, profound muscle weakness, slow, irregular pulses, hypotension, abdominal pain, nausea, vomiting, salt craving. They crave salt a lot. Weight loss, low blood glucose levels, low serum sodium levels, low serum potassium levels, and low serum cortisol levels. And this is all due to acute adrenal insufficiency. We know that a normal potassium is 136 to 145. So you kind of need to know that. We know a normal sodium, if I said potassium, shame on me. But normal sodium is 136 to 145. And remember, normal potassiums, I always remember 3.5 to 5 bananas. Fasting blood glucose, a normal level for that is 70 to 110. So it's very important, and I mean, this is very important to make sure we teach our patients to never, ever, 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 ever stop their steroids unless they talk with the healthcare provider first. These drugs, they need to be slowly decreased or tapered down to allow those adrenal glands to restart production of cortisol again. So that's very important that we do that. So before we give any of these corticosteroids, we want to make sure we have the correct med and the dose ordered. Don't substitute because of the different strengths. And you can see that on page 86. What the doctor orders, you need to get that. We're always going to look for any signs of infection because we know corticosteroids can make that infection worse, so we better report it. And always make sure you get a blood pressure and weight, okay? Because if you remember, and I'm going to flip the page back on page 88, one of the things is hypotension. So that's why it's very important to make sure we get a blood pressure, okay? So we're going to make sure we do that. Also, side effects, think of it. The hypertension, besides that, hypertension, not hypotension. Hypertension, sodium and water retention, and weight gain. Those are the ones we're worried about. After we give the corticosteroids, always repeat vital signs every shift. Make sure you check a blood pressure because we're concerned about the blood pressure getting elevated. Also, we want to make sure we check a temperature because temperature, if they start getting one, that could be a sign of infection occurring. We're going to weigh them daily because we know it retains sodium in water, and that can cause a lot of swelling. And we're going to inspect the skin because we know that it can cause a lot of bruising, and their skin is very fragile. So we're going to make sure we check that. We're going to teach the patient never, never stop. I'm going to say it 20 times. Never, 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 never. I don't think it's 20 times, but never stop their steroids suddenly, especially if they're on long-term or high doses. Talk with the physician so we can taper them down and get you off of them if you don't want to take them. If you're unable to keep your meds down, maybe you're vomiting, you need to notify the doctor because you can get them another route. They can upset your stomach, so we do recommend taking them with food. Remember the decreased white blood cell count. So in the inflammatory response. So we are definitely, those patients are at risk for getting infections. So we need to tell them avoid crowded areas. And we also need to tell them to stay away from sick and dirty little kids, I always say. It does delay wound healing, and the blood sugars on corticosteroids will increase when they're on these medications. So we definitely have to watch our diabetic patients. We need to monitor their blood glucose levels more frequently, and we need to adjust their diabetic medication in order while they're on, the steroids. Sometimes you'll see the doctors actually start them on insulin while they're on the steroids, and then once they're off the steroids, they'll take them off of it, and then, they can go back to their regular medications. Now, topical corticosteroids, those are used for skin inflammation. They can be prescribed. You can find them over the counter. They do soak in the skin, and they can cause those systemic effects. So it's very important to remember with the topical corticosteroids, we only apply a thin area, only to the area needed. Don't slather it all over and use a tube of it. Don't apply it anywhere else, and definitely on the skin that may be infected. We don't want to apply that on there. Now, pediatric population, the same issues as an adult can occur. And the pregnant and breastfeeding population, it does cross the placenta. Taken the last 3 months, babies are normally smaller in size, and it does pass in the breast milk, so it's not recommended to breastfeed while you're on it for long-term use. Now, our older population, those are the ones we're going to be concerned about because their immune system, as you get older, decreases, which puts you at risk for infection. The skin is also thinner, so lower doses of the topical drug is used. And because the majority of the time when you get older, that's when you get diabetes. So increased blood glucose level, especially with our diabetics, like I said, adjust their medications and talk with the doctor in regards. But like I said, for the corticosteroids, never, ever, ever stop them, especially when you're on them a week or longer or you're on high doses. So that is the first one of our anti-inflammatories, one of the most important ones that we give. Now, second one we kind of give on a daily basis, some people take on a daily basis, and these are our NSAIDs, which are our non-steroidal anti-inflammatory drugs. Not same as cortisol, not the same as cortisol, which is a steroid, but works like a corticosteroid on the body without those bad side effects and adverse effects that occur. That's why it says non-steroidal. You can get them prescription, you can find them over the counter. And on page 90 is some common steroid drugs that we have. Let me go to page 90. Okay, and some of our common non-steroidal anti-inflammatory drugs, salicylic acid, which is aspirin. A lot of people take aspirin, but that is a non-steroidal anti-inflammatory drug. We have propionic acid, ibuprofen, naproxen. Those are the big ones. Acetic acid, indomycin. We don't use that too much. Occasionally that comes out, but we do use ketorolac a lot, which is Toradol. Then we have, of course, those are COX-1 and our COX-2, celecoxib, which is Celebrex, and meloxicam, which is Mobic. We do give a lot of those ones out there. So these are the ones we do give a lot over the counter. We also have the prescribed ones. Inhibit the COX-1's enzymes. Those are like the housekeepers of the cells, and you can read up all about that. And the COX-2 ones, those are the inflammatory mediators. So like I said, just read up on the biology part so you know what the difference is. And the COX just means the cyclooxygenase. It's an enzyme that causes inflammatory responses. NSAIDs will actually block these COX enzymes, so they are inhibiting the action of that process. So they will actually inhibit the COX enzymes happening. So the intended response of these medications was it will decrease redness and pain, swelling, and warmth at the infected site. It will increase body function that inflammation caused, and it also helps with fever, because how many times do we give ibuprofen for fevers? But the side effects, the common side effects are on page 91. The big thing is it will cause bleeding problems. It can cause GI ulcers. It can cause a lot of pain. It can cause fluid retention as well as hypertension. So those are some bad things that do occur with these medications. The COX-1 inhibitor NSAIDs, they will decrease clotting of blood and decrease platelets from sticking together. So that's why you're going to have bleeding problems. That's where you get the aspirin or this um, salicylic acid. That's aspirin, so it's going to cause bleeding problems, as well as our ibuprofen can cause bleeding. Usually it's prescribed our salicylic acid or aspirin for this reason. That's why we a lot of times give it for people who have myocardial infarcts, because we want that to happen. We want the decreased clotting of the blood so their blood doesn't clot up and cause another heart attack. We do give to patients with cardiac issues. So that's, like I said, is a part of the acronym MONA, M-O-N-A, that we use for cardiac heart attacks or myocardial infarcts. The M would be for morphine, the O is for oxygen, N is for nitroglycerin, and the A is for aspirin. So we actually use that a part of our treatment when we have someone who's coming in with active heart attack. One dose of aspirin can decrease clotting up to 1 week, while other NSAIDs only decrease clotting while on the medication. So it's very important to make sure it takes 24, remember 24, it takes up to 24 to 48 hours, so 24 to 48 hours for clotting to return to normal after stopping. So it's important to stop these meds a few days before any invasive procedure so you don't have a lot of bleeding. And a lot of times the doctor will say, hold that medication for a couple of days, but it can be any time from anywhere from 24 to 48 hours, anywhere in between there. Fluid retention, that happens because it will decrease the blood flow to the kidney, which will decrease urine output, which will cause kidney damage and can also cause hypertension, which is a side effect. So that's why it's very important to make sure we weigh ourselves daily when we're on these medications for a period of time. Aspirin is the only NSAID that doesn't decrease the blood flow to the kidney. That is the only one that will not cause that issue, does not decrease the blood flow. If you take ACE inhibitors, which is an angiotensin converting enzyme, it will make that medication less effective. And we're going to learn about this later. And this was the COX-1. Now, our COX-2 inhibitor NSAIDs, you only see if you take more than prescribed, you'll see stuff with it. Then you'll have some side effects as the COX-1, except it doesn't affect the platelets or the blood clotting. So your COX-2, your celecoxib, and your meloxicam are the only two that will not affect the blood like the other ones. Now, adverse effects of your NSAIDs, kidney damage. It will bring on an asthma attack. It can cause allergic reactions. If you have any issues with one NSAID, most likely you're going to have problems with the other NSAIDs. So when they say I'm allergic to NSAIDs, most likely they will not give you any other ones because you'll have issues. Your COX-2 inhibitor NSAIDs can cause heart attacks or strokes because remember, it doesn't affect the clotting factor. So your COX-2 ones can cause heart attacks and strokes. If you're allergic to sulfa, very important, if you're allergic to sulfa, you can't take celecoxib, which is Celebrex, because the drug has sulfa components in it. So we cannot do that. So before we give NSAIDs, always check the orders. If you're allergic to sulfa, no celecoxib, which is Celebrex. Ask if you have any problems with any other NSAIDs because, like I said, if you have a problem with one, you're going to have problems with others. Give it with food or after a meal to prevent those GI issues that can occur. Have the patient drink a full glass of water or milk with these meds. And don't chew or open the enteric-coated tablets or capsules because you can cause harm to the GI lining. Make sure we check the blood pressure frequently because you can retain fluids and it could cause hypertension. And if you're on an ACE inhibitor, if you're on an ACE inhibitor, it can decrease the effectiveness of that medication. So that is important to know. After we give the NSAIDs, our COX-1 inhibitors, we're going to watch for any signs of bleeding. We're going to recheck the blood pressure and we're going to look for any signs of allergic reactions. We're going to teach the patient eat with these meds, look for signs of bleeding, and report immediately if you're having any problems. If you're going to have any invasive procedure, you need to stop these meds within 24 to 48 hours. If you take warfarin or Coumadin, you shouldn't take any aspirin or NSAIDs unless okayed by a healthcare provider because it can increase your risk for bleeding or strokes. Take it as ordered. Never take more than 2 NSAIDs at one time. And make sure you weigh yourself and report a gain of more than 3 pounds in a week because that means you're retaining a lot of fluid. Now, the pediatric patients, we do give ibuprofen, Advil, or Motrin as the only is recommended, but we do not give ibuprofen to infants less than 6 months. It is weight-based. We never, ever, ever give aspirin because kids can develop Bray syndrome if they took aspirin and had a viral infection, which can lead to liver and brain problems. So we would never give aspirin to any child. If yet they have chronic inflammation, doctors can prescribe aspirin or other NSAIDs, but they cannot have a viral infection before they start those. But that's only a direct thing with the physician. Now, the pregnant population, if they take indomethacin or celecoxib, we do not give for the last 3 months of pregnancy because it will actually close the major vessel for fetal circulation and oxygenation, that ductus arteriosus. So they should never, ever, ever take indomethacin or celecoxib if they're pregnant because we do for the last 3 months because we don't want to close that duct up. Now, the older adults, more problems with cardiac issues. They retain more salt and water on these meds, except for the aspirin. They do put them at risk for hypertension and congestive heart failure. We do need to monitor their weights daily, their pulses, and their urinary output. And we need to treat the signs and symptoms of heart failure. So that is the second one, our NSAIDs that we talked about. Now, also with that is with the salicylic acid, we can actually check a level of aspirin. We can actually do a salicylic acid level to order it to see if a patient is on, if they're taking their aspirin or if they overdosed on aspirin. Because a lot of times if people are overdosed on aspirin, they will have something called tinnitus, which is ringing in the ear. So a lot of times if the patient says I have ring in the ear, they may check and see if they're on aspirin. And if they are, they may check a level and see if it's toxic or not. All right, so that is the second one. Now, the third one is our antihistamine or histamine agonist. These drugs will decrease inflammation. If you have an inflammatory response, it will stop or prevent a reaction. It is used for allergic reactions. So if you have hives, rashes, watery eyes, runny noses, or severe allergic reactions like anaphylactic reactions, a lot of times we'll give you diphenhydramine or Benadryl in order to take care of that. Okay. They're intended responsive. They will decrease swelling, decrease secretion, so they'll dry you up because you have runny nose, watery eyes. It will dry you up. The airway opens up more. It will decrease the hive size, and it will decrease itchiness. So the common ones on page 94, let me get to 94. Cetirizine or Zyrtec, great thing to take. Diphenhydramine, which is Benadryl, which we give to everybody. And of course, loratadine or Claritin. All three of those we give a lot of. In the hospital setting for allergic reactions, we give diphenhydramine, which is Benadryl. But the common side effects for these H1 histamine blockers is it can cause drowsiness, okay? And the big thing with it is diphenhydramine. A lot of people take Benadryl to go to sleep, get a good night's sleep. So it's not uncommon. These medications can cause drowsiness. Now, the bad thing is if you're drinking alcohol, it can make that drowsiness symptom worse. So we do not recommend drinking alcohol when you're taking these drugs. They do cause dry mouth and blurred vision. Now think about it. If it's drying up the secretions, your mouth is going to get dry. Blurred vision, it dries kind of thing, and it will dilate the pupil. I always say so it dries it up. Anytime you have blurred vision because it's drying up the eye, that puts people who are at who have glaucoma. It can make glaucoma worse and lead to blindness, and that's usually one of the adverse effects that occurs. We'll talk about in a second. So dry mouth, blurred vision, you'll get dilated pupils, and increased heart rate. Think you're drying everything up, heart rate increasing, increased blood pressure, and you can actually have urinary retention. So you're not peeing a lot because it's drying everything up. You're holding on to things, you're drying up. Not good if you have urinary retention to prescribe it for people who have enlarged prostates. It's not good to prescribe it to anybody with hypertension because that can, or other issues with urinary problems. Now, adverse effects, on the other hand, like I said, because you're drying up the eye, it can make glaucoma worse and can lead to blindness because you're going to increase the interocular pressure, which is the IOP. It's rare, but you can have allergic reactions to them because these are what we give for allergic reactions. So it's very rare to have an allergic reaction to it. Don't give to patients who are having acute asthma attack because it can make them drowsy, and we don't want them to have, not work hard to breathe. We want them to work hard to breathe. We don't want them to slow down the breathing because that can cause them problems. Before we give any antihistamines, we want to know if they have a diagnosis of glaucoma, hypertension, or prostate problems, because we know these meds can make those worse. Because these meds can make you drowsy, check to see if any of the other drugs that could make you sleepy, like if you're on opioids, sedatives, muscle relaxers, or barbiturates, because it can actually cause more issues. And if you are taking those medications and need to take these, make sure you take them at least 4 hours apart. Afterwards, we're going to give these antihistamines. We're going to check the vital signs every 4 hours for the first 8 hours after we give the first dose. We're going to notify the doctor of irregular heartbeats, change in blood pressure, decreased respiratory rates below 10 breaths per minute because of the drowsiness effect. Teach the patient to stay away from alcohol, no driving within 6 hours of taking the med, notify any visual changes or pain over the eyebrow. And that's because that's due to the increase in intraocular pressure. A lot of times people who have glaucoma, if they start getting that pain over the eyebrow, probably their intraocular pressure is increasing. Notify the doctor if they have any history of prostate problems and urine output decreasing, or they can't void. And don't take if you're having any acute asthma attack, because remember, again, we don't want them to be drowsy, and that's going to affect their breathing, so we don't want that. So that is the third one, our antihistamines. Now, the fourth one are leukotriene inhibitors. These are found in white blood cells, leukotriene, leukocytes, white blood cells. These drugs prevent allergic reactions, and they decrease the inflammatory actions due to allergies. Their intended responses are decreased swelling of the mucous membranes. They are going to decrease secretions, and they're going to open the airway. So medications for these ones you can find on page 96. Montelukast sodium, which is Singulair. That is probably the biggest one I've given, and we usually give that for asthma patients. Now, the last one, the Zolutron, will actually affect the white blood cells. But the first one, this Montelukast sodium, Singulair, and I always remember Singulair, air as in breathing, that is used for our asthmatic patients. The side effects for them, and you can see that on page 96 also, the headache and abdominal pain. Adverse effects for these meds, liver issues. You can have yellowing of the skin, dark urine, tan light stools, pain to the right upper quadrant of your abdomen. These are signs of liver problems. So these medications or leukotriene inhibitors will affect the liver. So we want to make sure we check liver function tests when they're on these medications. It is very rare, but allergic reaction rare-wise, you can have an allergic reaction. You can have hives or an anaphylactic reaction. Montelukast sodium or Singulair can cause mood changes. So if anybody is on Montelukast sodium and they start having mood changes, or they start having some suicidal ideations or depression, you need to notify someone and tell them about that. So before we give these meds, ask if they're having any liver problems in the past. Baseline liver function test is going to be important to make sure the liver functions good before we start them. Afterwards, we're always going to be looking for signs and symptoms of liver failure. We're going to recheck those liver function tests afterwards, make sure the meds are okay, and report immediately if any suicidal thoughts or depression while you're on Montelukast sodium or Singulair. Teach the patients, report immediately any skin changes in color, right upper abdominal pain, and when I say skin in color, like yellowing, because that's with the liver, that right upper abdominal pain, dark urine, light color stools, like tan, sandy stools, and if they're depressed or having suicidal thoughts. And always get those repeat liver function tests. They need to repeat them. Pediatric population, we do give for allergies and inflammation. Usually it's smaller doses. They do have a tablet that they can actually chew. Now, the last but not least is our DMARDs. And our DMARDs is a disease-modifying anti-rheumatic drugs. These are used to treat many chronic inflammatory disorders, as well as a lot of our autoimmune disorders. They will help decrease the progression of disease. They will help prevent further tissue damage. These are very important ones. So their intended responses are to decrease pain and other disease symptoms, improve function, decrease physical damage that occurs with the disease. Now, our common DMARDs are in 97, okay? Now, the big one that we do give, adalimumab, can't say it all the time, Humira. And if you notice, these are given sub-Q, both of these, and etanercept, which is Enbrel. Both of those are given a lot. They're injections that people will take, and sometimes in the hospital setting, we will give these medications to the patients. They can be given by injection. Some of them are given by pills, but majority you'll see that. If they're given by injection, they're usually given sub-Q weekly or every other week. But side effects do occur, and that's on the same page with that meds. It can cause hot headaches, nausea, and of course, anytime you do an injection, it can cause injection site infection or issues like pain, swelling, redness, itchiness, and usually can happen 3 to 5 days after you give it. Adverse effects, it will decrease your body's entire immune system, and it can cause diseases that are dormant to reactivate. So if you've had a history of tuberculosis or hepatitis and it's been dormant, it can actually restart them back up. That's why it's very important before we do this medications, we always check to make sure that they do not have tuberculosis or hepatitis. Remember, anything that is going to affect your entire immune system, it's going to suppress your bone marrow. And when we suppress the bone marrow, we're suppressing white blood cells, red blood cells, and platelets. We know if we decrease our white blood cells, it puts you at risk for infection. If we decrease your red blood cells, it puts you at risk for anemia. And if we decrease your platelets, that's going to cause you a risk for bleeding problems. So suppression of the bone marrow, these people have to be very cautious and very careful for what they do. They have to stay away from crowds. They have to be careful of bumping their arms. They have to get their levels checked frequently. These medications can make heart failure worse. They can cause allergic reactions, anaphylactic reactions. Why? Because they're made from human components. Any medications that's made from human component or animal component put you at high risk for anaphylactic reactions, allergic reactions, because you're taking in something from an animal or human. So before we give, we want to make sure they have no active infections. If they do have an active infection going on, they're going to delay giving this medication until that infection is cleared up. We want to make sure no history of tuberculosis or hepatitis because it can reactivate. And it is one of the contraindication for DMARDs. We would not give them if they've had a history of tuberculosis or hepatitis. We want to make sure we check the solution. Adalimumab is clear in color with no particles, while etanercept can have particles but clear in color. We want to check the drug expiration date. Never mix any of these drugs together. First dose is given by a healthcare professional because we need to make sure we watch them that they don't get an allergic reaction, and we need to take their vital signs before they give the med and afterwards. Afterwards, after the first dose, patient needs to wait at least 2 hours so we can monitor for adverse effects. We're going to repeat their vital signs in 5 minutes, then 15. And we're going to have emergency equipment at the bedside in case they do have an anaphylactic reaction, an allergic reaction. And of course, let's document any issue that's going on with these meds. That's important. Now, with our we're going to teach our patients, we're going to teach them about infection symptoms or, signs of it. And if they are getting them, to report it right away to a healthcare provider so they can get treatment. We're going to teach the patient how to give themselves the injection, or may have to teach a family member how to give the injection. Pregnant and breastfeeding populations, sub-Q drugs are safe during pregnancy and breastfeeding. The oral drugs that are very teratogenic. So if they are taking the oral form, they need to use true reliable forms of contraceptives. So that means we will be checking see if they're pregnant before we start the medication, and they have to use two reliable forms of contraceptives. And absolutely no breastfeeding with the oral form. So that is chapter 6, our anti-inflammatory drugs that we can give to people to help with their things. So any questions, you know what to do, call me.